Okay, good evening. Good evening, everybody.
Good evening, sir.
As surgeons, we face, despite our best work on the operating table and having prepared the patient well before surgery, there are four things that haunt us post-operatively. One obviously is a chest infection. Second is urinary tract infection. Third is surgical site infection. Fourth is deep vein thrombosis and possibly pulmonary embolism. So these are four complications we need to be worried about. We need to think pre-operatively to stratify these patients and take necessary precautions to prevent them as much as possible. So deep vein thrombosis, all of these come under the superheading venous thromboembolism. So what is the definition of venous thromboembolism? Abnormal coagulation and thrombus formation in deep veins and in the pulmonary artery and its branches. So this is the spectrum of deep vein thrombosis possibly causing pulmonary embolism. Broadly, the venous thromboembolism is classified into provoked and unprovoked. I will come to that later. There are other thromboembolism, visceral, splanchnic, portal circulation, pelvic, cerebral, and upper limb. Today, our concentration is going to be on deep vein thrombosis and pulmonary thromboembolism. This could be fatal, or it could lead to superior vena cava syndrome as far as the pulmonary embolism is concerned. And in the deep veins of the leg, it can lead to chronic venous insufficiency and reduced quality of life, of course. Asian countries were believed to have lower incidence in both the deep vein thrombosis and pulmonary embolism, but this incidence is now increasing, possibly due to increased affluence and lifestyle modification. We all know the Burkhouse triad. This initiates the phenomena of venous thromboembolism, traces of blood, hypercoagulability, and endothelial injury, which could be initiated by the surgical procedure. Stasis because the patient is lying on the operating table and in the post-operatively in his bed. And then there could be potentially hypercoagulable state, which could be induced by dehydration and this could all lead to formation of blood clot. So let us go into the incidence of deep vein thrombosis and pulmonary embolism. It's about, Indian data is not available, but Western data suggests 53 to 162 per 100,000 population is fairly significant, and pulmonary embolism also in the same vicinity, 39 to 115 per 100,000 population. If you look at the fatality with deep vein thrombosis is about 6% and pulmonary embolism is 12%. You should remember 30% of pulmonary embolism are asymptomatic. So you need a very high index of clinical suspicion to think about pulmonary embolism and diagnosing. There are two risk factors in the two main headings, inherited and acquired. Men surprisingly are more prone to developing only recurrent deep vein thrombosis is similar in men and women, but recurrent DVT is more common in men, and so is pulmonary embolism. African Americans have a 30 to 100% more chance of developing venous thromboembolism than the white population. Now let us look at the inherited causes. So these inherited causes are in the general broad heading of thrombophilia. The main ones are the factor V Leiden mutation, prothrombin gene mutation. Much common ones which we know about are the protein C and the protein S deficiency, antithrombin deficiency, and dysfibrinogenemia. So these are all the inherited causes. So in patients who have this, predilection to developing venous thromboembolism, if you add the acquired causes, then they are more likely to develop pulmonary thromboembolism. What are these acquired causes? Orthopedic operations, total knee replacement, total hip replacement, and hip fractures, neuro operations, long drawn out neurological, neurosurgical operations, and oncosurgeries, especially pelvic surgeries or long duration oncosurgeries. There is a 5 to 11% increase in the venous thromboembolism. Prolonged travel both by air and by land also causes 2 to 4-fold increase in the incidence of venous thromboembolism. Presence of a venous catheter either for purposes of feeding or for delivery of chemotherapy in patients with cancer. And if these catheters are not placed in the interface between the superior vena cava and the right atrium, then there is chance that these catheters may cause injury to the venous wall and then setting off the varicose triad. And because either the chemotherapeutic agent or the total parenteral nutrition, whichever the case may be, are hygroscopic and hyperosmolar solutions. So there is potentially increased hypercoagulability because of that. And then there is trauma to the vein wall, and that induces venous thromboembolism. So long-standing venous catheters have and again with cancer chemotherapy, also the patient with cancer also have a hypercoagulable state. And again, that predisposes them to develop venous thromboembolism. Malignancies, main ones which we know is the Armand-Trousseau sign in patient with the carcinoma head of the pancreas, carcinoma of the ovary, stomach. In fact, Armand-Trousseau diagnosed his own cancer, which he believed was pancreas, but unfortunately it was stomach. So that is how he described the sign of migratory thrombophlebitis. Renal carcinomas, melanomas, lymphomas, breast cancers, and glioblastoma. That's grade 4 astrocytomas of the brain. So these are the common, you can develop venous thromboembolism with any malignancy, but these are the more common ones. Smoking and obesity. I think they are self-explanatory, and trauma also. Sometimes even minor trauma can cause deep vein thrombosis. Pregnancy and postpartum, there is a 5 to 50 times higher risk of developing venous thromboembolism. As you can well understand, the weight that goes on the pelvic veins and the inferior vena cava due to the increased intra-abdominal pressure, and the weight, physical weight being transferred onto these veins by the ever-enlarging uterus could cause decrease in the flow through the pelvic veins and the inferior vena cava, and that could lead to stasis and then pulmonary embolism. Bed rest for more than 3 days. Chronic medical conditions, I'm going through the list. I'm sorry that, but I have used all the accepted short forms. I have not been able to expand them for lack of space. Atherosclerosis, myocardial infarction, chronic heart failure, hypertension, dyslipidemia. These are the medical conditions. Renal, chronic renal failure and nephrotic syndrome. Hematologically, polycythemia and polycythemia vera. Rheumatology, rheumatoid arthritis and systemic lupus erythematosus. In gastrointestinal diseases, inflammatory bowel disease, respiratory, bronchial asthma and obstructive sleep apnea. In endocrine causes, you have diabetes mellitus, and drugs. Commonly, there are many drugs, of course, but the common ones are oral contraceptives, tamoxifen, and steroids. So these are the main acquired causes. So now let us come to what is called as the pre-assessment. This is the most important aspect of my talk. Wells in 1997, and then subsequently modification of his initial criteria in 2003, come up with what is called as the pre-assessment or the DVT probability score. Active cancer treatment gets a point, paralysis, paresis, plaster immobilization, recently bedridden, 3 days or more, major surgery within the previous 12 weeks, localized edema along the deep vein system, swelling of the entire leg on the side possibly, calf swelling taken at the same level below the knee joint, being more than 3 centimeters in one leg than the other leg, pitting edema of the symptomatic leg, collateral superficial circulation, and previous documented DVT or PE. So each of these will get a point. So if the score is 0, it is called low probability with a 5% chance of developing DVT. Score between 1 and 2 is called intermediate probability with a 17% chance of developing pulmonary DVT and pulmonary thromboembolism. 3 or more causes high probability with a 53% chance. So this is the cornerstone on which the management of deep vein thrombosis revolves. So whether it is treatment, whether it is prophylaxis, Wells DVT probability score is the main plank on which the treatment hinges. It is a very accurate thing for outpatient assessment. So a patient who comes to you in the outpatient with these symptoms, then it is very accurate. But if the patients are already admitted post-operatively or for some other medical reason, the big list that I've already put up, then you have to have a very high index of suspicion for inpatients. There are several risk assessment models, what are called RSMs, for prediction of the predilection, prevalence, and then the severity of venous thromboembolism, but many of them are poor, inaccurate, and inconsistent. So this is the algorithm on which you base your management. This is just, I put it up. I will go through the management in more detail. So first patient who comes with suspected DVT, and according to the pretest probability score, if it is not high, then you do D-dimer. If the D-dimer is negative, because D-dimer has an excellent negative predictive value, then you can rule out DVT and you don't need to treat them. If, for example, the D-dimer is elevated, then you do a complete compression ultrasound scan, and that is positive, then it obviously indicates DVT. If the pretest probability score is high as well, and then if the D-dimer is high, then again, with the ultrasound, you confirm the presence of DVT and then treat it as DVT. If the compression test is inconclusive, you repeat the compression ultrasound after 5 days. Alternatively, you can do venography, and if that is positive, then you treat it as DVT. If the ultrasound scan again has a very good sensitivity and specificity rate, I will come to that later, DVT is ruled out and you don't need to treat. If the ultrasound subsequently also is negative, then again DVT is ruled out. So as you will see, D-dimer, the Wells probability scoring, and the ultrasound scan form the significant investigative modalities and clinical modality to make the diagnosis of venous thromboembolism. Now let us come to pulmonary embolism. There is what is called as a revised Geneva score, which again gives points accordingly. Age above 65 gets 1, previous DVT and pulmonary embolism gets 3, surgery under GA or fractures of the lower limb less than a month time gets 2, unilateral lower limb pain gets 3, hemoptysis 2, heart rate between 75 and 94 gets 3, but heart rate above 95, tachycardia, gets 5, and pain in the lower limb, deep vein palpation or edema gets 4 points. So what is the significance of this scoring system? A low score of 0 to 3 means it's low probability of pulmonary embolism, intermediate 4 to 10, and high is more than 11. So let us look at this picture. It's got a lot of signs. You see there is a other leg for comparison. You can see it's discoloration, reddish discoloration, and shiny leg, swollen. You can see there is significant difference in the two legs. So the right leg has got deep vein thrombosis in this patient. So what are the symptomatology and clinical signs? Pain, swelling, discoloration of leg. It's only present in about 23 to 50% of cases. So again, as I say, you need to have a high index of suspicion. Dyspnea, pleuritic pain, hemoptysis, cough, and syncope. These things are symptoms of pulmonary embolism. And then when you come to the signs, tachypnea, tachycardia, elevated neck veins, and JVP, elevated JVP, all of them indicate that possibly it is one of the pulmonary embolism. Again, systolic BP less than 90 or a drop of more than 40 millimeters of mercury from the previous recording indicates possible pulmonary embolism. I will come to the other signs later. Now, coming to the diagnosis. Venous Doppler is one of the mainstays of the diagnosis of deep vein thrombosis. It is an excellent diagnostic tool with a 95% sensitivity and 96% specificity, especially in the low and the intermediate risk group. So I keep coming back to this Wells, severity predictive score, which forms a very important basis on which you have to investigate these patients. So if you have low and intermediate risk group, it has a very, very significant predictive value. You use a 7.5 megahertz linear vascular probe, and generally, as you know, ultrasound is observer dependent, and so the dedicated sonologists tend to get better results. And also you can use the 2D mode and 3D mode and also the color Doppler to get a better value. What you do in the casualty when the patient comes with severe symptoms suggestive of pulmonary embolism, and you see that the leg is swollen, you can use double compression. That is, in the emergency situation, that is one compression at the groin to look at the deep vein at that point, and also the other compression in the popliteal region. And these two will usually sufficient to tell you whether there is DVT or not. But then you can complete the subsequent examination, which is to go carefully along the vein from the groin towards the knee and beyond. So that is the complete compression ultrasound, but sometimes a double compression should be sufficient if you are able to prove that there is DVT. Venogram is the gold standard, but hardly ever used in patients with high suspicion. But if the Doppler and D-dimer results are equivocal, you have to then go ahead and do a venogram. Now coming to the D-dimer. There are many ways of checking the D-dimer, but the ELISA, or that is enzyme-linked immunosorbent assay, is the best technique to determine the D-dimers. Values above 500 micrograms gives you a 95% sensitivity. It is a test which has an extremely high degree negative predictive value, which means if the D-dimer is not elevated, then the chances of the presence of DVT and pulmonary embolism is less. So, but however, there are special situations like in the elderly patients, pregnant patients, cancer, and its patients who are on treatment for cancer, and patients who are already on anticoagulant therapy for other reasons, and patients with renal failure. What do you do in these situations is you have to set a higher value. That is, for example, you may even go up to 2000 micrograms in patients with cancer, and even with cancer and its treatment, you can even go up to 8000. So when you go to that level, then your predictive value becomes good. Otherwise, 500 micrograms is good for most of the other situations. The ones which I have already enumerated, these you have to be a bit more careful. So now coming to the other tests that we do in venous thromboembolism, you do a blood gas analysis, which shows hypoxia, hypocapnia, and respiratory alkalosis. Again, all non-specific findings. There is something called brain natriuretic peptide, BNP. This identifies patients with high death and adverse outcome events. So it may not necessarily, if it is elevated, then it shows to you that there is a very high chance the patient may die or may have very severe, adverse outcomes, patient depending on ventilator, long ICU, dialysis, and all those things. And it also has a high negative predictive value, which means if it is negative, then the chance of DVT or pulmonary embolism being present is less likely. ECG again is non-specific. You can get tachycardia, ST segment changes. S1Q3T3 pattern is very classical of pulmonary embolism, very present in about 40 to 50% patients only. You can also have a right ventricular strain pattern and right bundle branch block. Chest X-ray again is very non-specific and not very sensitive, but it can show an enlarged pulmonary artery and it can show something called a Hampton's hump, which is a peripheral wedge of airspace opacity present in about 20 to 30% of people. Westermarck sign, which shows regional oligemia in a particular area, again present in about 10 to 15% of patients. Pleural effusion can be present in about 35%, bilaterally in about 20% of people. So, shall I stop here and ask for any questions, any clarification so far? Tanya? Hello?
Can you explain double compression test once again?
Yen Guru?
Can you explain double compression test once again?
See, the double compression test is a test that is done urgently in patients, for example, who have come to the casualty with high suspicion of pulmonary thromboembolism or very severe, phlegmasia or things like that. You take the ultrasound Doppler probe and do the compression at the level where you can compress the femoral vein, and then you do the compression at the popliteal level of the popliteal vein. So if these two veins are non-compressible, then it indicates to you that there is a very high chance that the patient will have deep vein thrombosis, which probably has led to the pulmonary embolism.
Deep vein thrombosis of calf vein or femoral vein?
For example, if it is non-compressible at the groin, then it obviously means it is at the femoral, that is the entire leg is involved.
Oh, okay.
Femoral. And if the calf vein is non-compressible, then obviously the calf, the popliteal level is not
below the level.
Then you can, when you have established the diagnosis, you can obviously go up and look at the IVC, iliac veins and all that. So that is the advantage of the double compression.
Okay.
Any other doubts so far?
Sir, you had mentioned that DVT is common in gynecological surgery. One of the why specifically gynecological surgery, sir? Is it because of the position?
Yeah. See, the thing is, many of them they operate on the pelvic veins. Around the pelvic veins, the patient position, and you're talking about Vardheims and other major hysterectomy or even laparoscopic assisted, hysterectomies and pelvic ovarian malignancies and things like that. So in that way, when you have a patient whose legs are up, if you don't take the necessary precautions of using the dynamic compression stockings and the and things like that, and still even with using all of these things, you can still develop deep vein thrombosis. So because of the, and also if there is any even small trauma to the surface of the vein, and that can lead to stasis and also and formation of clots.
Okay.
Anybody, any other question? So far, everything is clear?
Yes, sir.
Speak up.
Yes, sir.
Indraja?
Yes, sir.
Nikita?
Sir.
Yes, sir.
Clear?
Yes, sir.
Okay, so this, amongst all the chest X-rays I looked at, this is one of the classical ones. You can see the Hampton sign and the Westermarck sign in this patient. See, this is the wedge of the Hampton sign there, and he has bilateral pleural effusion and also oligemia of the both bases, more so on the right side. So there's a Westermarck sign. So he has all three signs of pulmonary embolism described. There are many more, but those are the three signs that are visible here. Now coming to the next examination, this is the CTPA. you can see the saddle embolus in the pulmonary artery, very classical. The saddle embolus, and this again, significant amount of clot in the pulmonary artery and its branches. You can see one of the branches with the clot there, again another branch with the clot there, and wedge-shaped opacities in the right lower zone. So these are the classical signs of venous pulmonary embolism. So CTPA, the PIOPED-2 trial was done to see establish what is the sensitivity and specificity of CTPA, and it shows a 93% sensitivity and 96% specificity, which is excellent. What are the advantages of CTPA? It is quick, readily available, and minimally invasive. It also gives you, many times patients come to you with chest pain and the diagnosis is not clear. You can also get, your views of the heart, the other aspects of the lung and the mediastinum and things like that, especially with contrast enhanced CT. You can make other diagnoses and other pathology also. So that's another advantage of CTPA. It is, the CT reporting uses the Hounsfield units, as you all know, and minimum intraluminal density of 93 Hounsfield units has to be there to diagnose an acute thrombus. That is the clot in the artery. It should be minimum of 93 Hounsfield units. And if you are going to diagnose a chronic thrombus, it has to be more than 211. So that is the diagnostic, the benchmark for diagnosing the pulmonary embolism. They use about 60 to 150 ml of iodinated contrast, which again obviously means in patients with impaired renal function, in pregnant women, it can't be used. So the classical sign is the filling defect seen in the artery, which is likened to a polo mint. And if you look at the horizontal or the transverse section, you will see it as a railway sign. That means there is a clot in between, and then there are the track, the strands going across. So that looks like a railway line. So this is the classical CTPA. What you can't, if you can't do CTPA, what is this? This is what is called as a ventilation perfusion subtraction scan or VQ scan. It used to be the mainstay of diagnosis before CTPA became the diagnostic sine qua non of pulmonary embolism. Before that, it was the VQ scan. So what do they do in VQ scan? Here you can see classically the right upper zone, there is the ventilation perfusion mismatch, and also there are multiple areas of involvement in both lungs, more so on the right side compared to the left side. So what is this VQ scan? It uses technetium-99m labeled with the DTPA or sometimes sulfur colloid. There are others, but usually they use DTPA. And initially, they do a perfusion scan, because if the perfusion itself is limited, then you know that the diagnosis of pulmonary embolism is almost there. If you do the ventilation scan first, it will not tell you. It will not tell you definitively whether there is pulmonary embolism or not. And again, you are using radiation. So hence, recommendation is to do the perfusion scan first and then do the xenon 133 ventilation scan. And you have to interpret it with the latest chest X-ray that is taken along with it. So that is the requirement of a VQ scan. And again, in the PIOPED-2 trial, they described 4 scenarios. High is possibility of venous thromboembolism, very low possibility, normal VQ scan, and non-diagnostic. So these are the 4 categories under which they report VQ scan. The VQ scan, it has an 83% sensitivity and 97% specificity. It uses 50-fold lower radiation dose. Hence, it is better in patients who are pregnant or suspected to be pregnant, in patients with renal failure, because it doesn't use the regular iodinated contrast. So there is no issues with the renal component of that. And in young patients and patients where you don't want to expose them to too much radiation, and patients who have contrast allergy. So this is the fallback option in patients in whom the CTPA is probably not indicated or contraindicated, or CTPA has been equivocal. So if CTPA is equivocal, you can still go ahead and do a VQ scan, which will help you to make the diagnosis. And then now let us come to the treatment. So basically, the initial treatment lasts for 5 to 10 days. Maintenance therapy lasts to 3 months. What is called as the extended secondary prevention can last beyond 3 months, depending, and it is variable. The period is variable depending on the thrombophilia testing, risk of recurrent episodes of pulmonary embolism, and also risk of bleeding. Fatal complications due to DVT and pulmonary embolism are highest in the first to fourth week of the onset of the symptoms and after you have made the diagnosis. Sudden cardiac arrest in patients with very severe or extensive DVT and pulmonary embolism is about 8%, and such patients do not survive. So what do you initiate the treatment with? You start with unfractionated heparin, what is called as UFH, low molecular weight heparin, LMWH, fondaparinol. I will come to each of them, and then there are two new what is called as the NOAC, that is non-vitamin K oral anticoagulants, which are NOAC, which are now becoming the standard of care in many of the patients with PE and DVT. So apixaban and rivaroxaban, these are the two new agents. They're not so new, but for us as surgeons it is new. These are the ones which you can actually initiate the treatment with. So as I said again, complications and death are highest in the first 2 to 4 weeks. So you have to be extremely careful. Where do you use the unfractionated heparin? In patients who have renal impairment and in patients where you think thrombolytic therapy may be required, both, for example, in patients who have phlegmasia alba dolens or phlegmasia ceruleus dolens, or in patients with what is called as unstable pulmonary embolism. You don't call severe PE anymore. You call it stable PE and unstable PE. That is the designated terms that are used with PE. So in patients with unstable PE, what you do is you start with heparin. So what the dose is 5,000 units bolus followed by 18 international units per kg per hour, which amounts to about 30,000 units in a patient who is 70 kilograms over 24 hours. You have to do the activated partial thromboplastin time every 6 hours in the first 24, and then every day for the next 7 days, and maintain the APTT beyond 2, preferably 2.5 to 3. So that is the recommendation. You continue this for 5 to 7 days. Beyond 5 days, you need to be very worried about the major complication, which is the heparin-induced thrombocytopenia, which can itself be very fatal. Patient can bleed to death or have a massive stroke. So you need to be very wary. Do the platelet count every day beyond 3rd day. And if it starts falling, then you have to stop the heparin. So that is the treatment with heparin. The next one is LMWH, which is much better, more predictable dose response, and hence does not need either regular monitoring or dose adjustment. It has a very low risk of bleeding and thrombocytopenia as well. It is started at a dose of 30 milligrams every 12 hours for the first 5 to 7 days, followed by either warfarin or NOAC. INR to be maintained between 2.5 to 3.5 depending on the severity of the DVT and pulmonary embolism, and for at least 3 months. And as I said, continuation beyond that depends on the severity and the chance of recurrence. So you don't need to monitor anything with the low molecular weight heparin. Coming to the other drugs, see as I said, non-vitamin K oral the agents act on the factor 10A of the coagulation cascade, which is very important. So the factor 10A, that is the junction or the common point between the extrinsic and the intrinsic pathway. So which is why these agents are extremely effective. But the apixaban and rivaroxaban have low renal clearance. So you can't obviously use them in patients who have renal impairment. So apixaban can be used to initiate the therapy at a dose of 10 milligrams per day for the first 7 days, and then 5 milligrams later for the next 3 months, twice daily. Rivaroxaban is started at a dose of 15 milligrams twice daily for the first 21 days, and then go on to 20 milligrams BD for the next 3 months. See, this edoxaban is also one of these factor 10A inhibitors, but cannot be used for the initiation therapy. If you have to use edoxaban, you have to start the low molecular weight heparin for the first 5 to 7 days, and then switch to edoxaban, which at a dose of 30 to 60 milligrams once a day for 3 months. The other NOAC is the dabigatran, which is again quite common, quite popular, and this acts as a direct thrombin inhibitor. So again, very effective, but it also has a high renal clearance. So it can be used in patients who have renal impairment. Again, the dose is 150 milligrams twice daily for next 3 months. After the initiation happens with, you can't use, as I say, a repeat, edoxaban and dabigatran cannot be used for initiation of therapy. You have to start with low molecular weight heparin for the first 5 to 7 days, and then add these two drugs, and then continue with them, and you can stop the LMWH. The other treatment which is used is what is called as a fondaparinone, and this is a factor 10A inhibitor again, and it's a pentasaccharide. So it doesn't have the allergy or thrombocytopenia which you see with heparin. It is a parenteral injection given subcutaneously. Initiation, again, the dose depends on the weight. For 50 kg person, 5 milligrams. For 75, for 50 to 100, use 7.5, and beyond 100, you use 10 milligrams for the first 5 to 9 days, and then you can follow that by either warfarin or NOAC agents. So let us look at the evidence so far about these drugs. The Einstein trial looked at about 8,280 patients using the rivaroxaban, comparing it with the low molecular weight heparin with warfarin. The recurrence of venous thromboembolism was 2.1 compared to 2.4%. So it compares favorably with the standard treatment, which is low molecular weight heparin and warfarin. Again, the bleed rate is less, much less, 1% compared to 1.7%. The bleeding is, I'm talking about severe bleeding, either in intracerebral bleeding or retroperitoneal or any other cavity. So this bleeding can be quite severe, which may need to cessation of therapy. Coming to the next trial, which is the Amplify trial, again using about 5,400 patients, it compared the apixaban with again the standard comparator arm. The recurrent rate was very favorable, 2.1 to 2.7%, and bleeding rate was very good, 0.6% compared to 1.8. So apixaban looks very capable and very favorable in terms of even recurrent venous thromboembolism and also bleeding. Focusite trial of about 8,300 patients compared edoxaban, again showing that it is reasonably okay in terms of both recurrent venous thromboembolism and bleeding. And dabigatran recover trial, about 5,000 patients, also compares favorably compared to the standard treatment, which was low molecular weight heparin and warfarin. Now, coming to we have now finished the initiation therapy and maintenance therapy. Where do you need to do extended secondary prevention? This you have to do individual risk assessment. Again, going back to the pre-assessment, high risk patients, intermediate and low risk patients. So there is what is called as a transient trigger. Like, for example, nobody usually undergoes major surgery all over again. So major surgery, trauma, illness, which requires hospitalization and immobilization, and pregnancy and long distance travel. These are all what we call as transient triggers. So if patients have had DVT or PE following these transient triggers, their risk of recurrence of PE or DVT is less than 1.8% per year, which is very low, because anything 8 to 10%, 12% is considered high. So these are low risk patients. So you don't need to carry beyond 3 months. The second group, where there is patients who have already had recurrent DVT or PE, patients who have had unprovoked, for example, with no risk factors, they develop DVT or PE, which means most of the time they will have either the thrombophilia, protein C deficiency, or dysfibrinogenemia. So such patients whose condition gets unmasked at the first episode of pulmonary embolism or DVT, such patients you may need to continue beyond. They're like all the inherited factors I told you. And patients who have cancer, these are patients, the cancer treatment itself, as I told you, the chemotherapeutic agents and the venous catheter that is there, and the cancer itself will cause hypercoagulable state. So these are things which can cause problems. So you need to continue in these patients. Previously, aspirin was considered a good, venous thromboembolism agent in the vitamin K, anti-vitamin K era. But now, because of the high risk of bleed, especially GI bleed and intracerebral bleed, actually what they say is patients, die more of the complications either in the form of GI bleed or cerebral bleed than those patients that are saved by using aspirin to prevent the complications. So you have to be very careful about using aspirin. The newer agents are much better, so you probably go with newer agents. And as I said, the NOAC has low risk of bleed and recurrence and probably are the treatment of choice now. Now, where do we use other things? For example, in patients who have cancer-associated venous thromboembolism, you don't use any of the NOAC agents. You use low molecular weight heparin or fondaparinol for a period of 3 to 6 months till you have completed the treatment. In patients with pregnancy, again, you can't use NOAC. You have to use low molecular weight heparin or fondaparinol. Patients who have had massive deep vein thrombosis, phlegmasia, and unstable PE, you have to use thrombolysis. In such patients, you have to use the unfractionated heparin. And contrary to popular view, patients who have had diagnosis of deep vein thrombosis need not be immobilized once you have initiated the treatment properly. That is the therapeutic level of treatment. You don't need to immobilize them. And patients who have symptoms of pain, swelling, and compression, you can use the compression stockings therapy for the period of 3 to 6 months and beyond. Now, coming to what is the pathophysiology in pulmonary embolism. There is a ventilation perfusion mismatch. There is a significant vasospasm of the vessels in the pulmonary circulation. This causes increased pulmonary vascular resistance, peripheral vascular resistance, and pulmonary artery pressure. This causes hypoxic vasoconstriction and decreased right ventricular outflow. This consequently causes right ventricular dilatation, decreased left ventricular output, and cardiac output. So everything is a chain. So initially, it is the right heart circulation that is affected, significant pulmonary hypertension, significant peripheral vascular and pulmonary vascular resistance, which then causes dilatation of the right ventricle, and then that has a negative effect on the left ventricular as well, as causing left ventricular and cardiac output to drop. So what is the treatment of venous, the pulmonary embolism? You have to use high flow oxygen, and sometimes you may have to use ventilator. You have to give them fluids, because sometimes the clot happens because of the dehydration. But again, you have to be careful. You don't give them too much fluid, because that again has a negative effect on the right heart pressure. You may have to use inotropes to increase the blood pressure. ECMO and low molecular weight heparin to be started, or ultra fractionated heparin, fondaparinol, any of these things to be started immediately. As I said, in ultra fractionated heparin in patients who are unstable and in whom thrombolysis is considered. Patients who are unstable and catheter directed therapy has to be done. So this is a very exciting area. So the catheters that are, put into the pulmonary artery, you can use it to, sort of break down the clot and suck them, and also give thrombolytic agents. And that is one of the, advances that has come in a big way. And so more and more radiological embolectomy is being done more than the surgical embolectomy, because that itself is a very high risk patient, strategy with significant post-operative complications and mortality. And in patients whom we can't do either the catheter directed therapy in the form of thrombolysis or breaking down of the clots and suction of the clot, thrombectomy, you have to then, and patients who are unstable, you may have to use the retrievable IVC filter. So why use retrievable IVC filter is because the IVC filters that are left behind will act as a nidus and also subsequent development of further recurrent DVT in that site. So once the IVC filter is put in and that the clot has been dissolved, and once you've established that, you should be able to retrieve the IVC filter so that it will not sit there and cause problems in future. So this is the picture showing the deployment of the IVC filter. As you can see it here, nicely seen, IVC filter sitting correctly in the inferior vena cava. So now coming to the deep vein thrombosis prophylaxis. See, it is either primary or secondary. So primary is you use it as a, in patients after risk stratification. And it is surprising that only 50% of patients coming to surgical wards receive prophylaxis. In patients whom you have stratified as low risk, you don't need to use prophylaxis. In patients with moderate risk, that is, score of 1 to 3 on the Wells score, you use pharmacological agents, either in the form of low molecular weight heparin or fondaparinol or even heparin for that matter, or even the drugs, the NOACs. Then if you think that the risk is, slightly higher, patients, for example, undergoing oncosurgery or orthopedic surgery and long-standing surgery, patients likely to be immobilized, then you may also use the mechanical prophylaxis. High-risk patients, you have to use, this is optional. In moderate risk, definitely pharmacological, possibly mechanical. In patients with high-risk strata, pharmacological and mechanical prophylaxis both have to be used. Usually the drugs, as I told you, low molecular weight heparin, 40 milligrams of LMWH, or 5,000 units, 8 to 12 hours of ultrafractionated heparin, or fondaparinol, 2.5 milligrams subcutaneously. So these are the standard drugs used for the pharmacologically. And mechanically, the intermittent pneumatic compression, graduated compression stockings, and venous foot pump. These are the agents that are used in the operating theater, especially patients who are undergoing anterior resection or AP resection or Wardheim's hysterectomy or pelvic lymphadenectomy for prostate cancer or ovarian cancers, and things are long-standing, long drawn-out procedures. Whipple's procedure, for example, you have to use pneumatic compression, graduated stockings, intermittent pneumatic compression, along with graduated compression stockings. So this is about the prophylaxis and prevention of deep vein thrombosis. So I think I have come to the end of my lecture. Now let us open this up for questions and any clarifications or doubts.
Hello, sir. Sir, prophylactically, how many days can we give, sir? Like after post-surgery?
Again, it's a risk stratification. See, if patients who you have started it in patients who have low risk and you have thought anyway, patients are in the hospital legally, you don't want to get into trouble, especially patients. So in such patients, the moment they leave hospital, you can discontinue. In patients with intermediate risks, you carry it on for about 15 days. So that is, both the pharmacological and the mechanical. And in patients who have high risk, patients who have already had pulmonary embolism or DVT, or patients who have had major trauma, major fractures, pelvic surgery, and such patients, you may want to continue that if there is no evidence of deep vein thrombosis already, patients are not very mobile, you have to continue that for a period of 1 month. By that time, if the patient is mobile and well, then you can discontinue.
Okay, sir. Thank you, sir.
Tanya? Any doubts? Clarifications?
Sir, just about post-thrombotic syndrome also, sir.
Ah.
2 lines.
See, the problem is, see, I could have talked about visceral thrombosis, portal vein thrombosis, and upper limb thrombosis, and post-thrombotic. See, the post-thrombotic leg chronic venous insufficiency is a topic in itself. See,
It would have been very vast, sir. It would have been beyond today's
Yeah.
system.
See, beyond 40 minutes, people's ability to, grasp and retain things are low. And because this is an extremely important topic, because you will certain to get this as a theory question, or in the exams or on the ward rounds, you will certainly be asked. One of you will be asked about deep vein thrombosis. So I restricted myself to the evaluation, prophylaxis, management of deep vein thrombosis and pulmonary embolism. You can talk about the pulmonary embolism and all the procedures that are there. That itself will be a big talk. So we'll talk about chronic venous insufficiency when you talk about varicose veins, because varicose veins, one of the things is deep vein thrombosis and CVI. So we'll talk about it then, which is why I didn't, because it will unnecessarily, become very difficult. Again, all the mesenteric venous, thrombosis, all these things are, they themselves are big topics on their own right. So I didn't touch upon any of those things. I just mentioned what are the, what are the things that are considered in venous, thrombosis or VTE, venous thromboembolism. Niranjan, any questions?
Nothing, sir. It was excellent and very comprehensive coverage of the entire topic. Thank you.
Srikanth? Hello, Srikanth?
ಏನು ಕೇಳೋದಿಲ್ಲಪ್ಪ, excellent talk, fantastic.
See, for the benefit of students, I've also sent 2 or 3 papers, review articles that I posted in our WhatsApp group. I have gone through the latest literature to give you what is currently accepted as the prophylactic treatment and as definitive treatment. So I have given you the various. See, for example, management of DVT-PE in pregnancy, in elderly, in patients undergoing orthopedic surgery, and all of these are topics by themselves. But I have just, given you the current accepted level 1, level 2 evidences for all of whatever I have said. They're all level 1A, level 2 evidence, nothing below that. So, and I've also sent you the review articles and also the definitive articles from very good journals. So go through them, and if there are any doubts, please post in the group and we will discuss and we will solve that.
Sir, if PPT no post forward, sir, it will be helpful.
Yeah, I'll post it. Yeah. Okay, so if there are no further questions, let us stop, and good night, everybody.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.